Hello, I'm Norman Swan. Welcome to this programme on the new guidelines for the non-surgical management of hip and knee osteoarthritis. It's a timely programme as we're broadcasting during Arthritis Awareness Week. Arthritis, as you well know, is a major cause of disability and chronic pain. And there's around 100 different forms of arthritis, and osteoarthritis is the most common. This programme is the third in a series of 4 on the musculoskeletal guidelines that have been developed by the Royal Australian College of GPs and approved by the NHMRC. This programme will cover the diagnosis of osteoarthritis and discuss recommended non-pharmacological and pharmacological interventions in a multidisciplinary primary healthcare setting. As always, you'll find a number of useful resources available on the Rural Health Education Foundation's website, rhef.com.au. Let's meet our panel. Jeff McCall is a rheumatologist and Professor of Medical Education and Training at the University of Melbourne. Welcome, Jeff.
Thank you, Norman.
Jeff's the current President of the Australian Rheumatology Association and was part of the working party developing this guideline. Rana Hinman is a physiotherapist and senior lecturer in the University of Melbourne School of Health Sciences. Welcome, Rana.
Thank you.
Rana has particular expertise in evaluating conservative treatments for osteoarthritis and was also a member of the working party. Michael Yelland is a general practitioner and associate professor of primary healthcare at Griffith University in Queensland. Welcome, Michael.
Welcome, Norman.
His teaching and research interests focus on evidence-based diagnosis and the treatment of musculoskeletal pain. And last and certainly not least is David Ung, who's a pharmacist and director of the South Australian and Northern Territory branch of the Pharmaceutical Society of Australia. Welcome, David.
Thank you, Norman.
From the home of fish oil.
That's correct.
And we'll be talking about fish oil later to see whether or not it's the magic panacea for osteoarthritis. Many myths about osteoarthritis, Jeffrey?
There are many myths, Norman. Probably the best place to start is that this is an illness that you acquire as you grow old, but you can do nothing about. And I think that what we're realising...
You're just going to creak your way to the brick wall at the bottom of the garden.
Absolutely, and there's a certain acceptance in the community. This is the way it will be. And
were you trying to tell me it's reversible?
It's the pathological process is not reversible, but the degree to which your function and pain is affected is reversible, so that if you work appropriately with some of the health professionals we have around the table, then you can improve your quality of life and perhaps avoid those major things like total knee and total hip replacements.
So you can slow it down significantly?
I think you can alter the natural history by affecting things like your weight, improving muscle strength around it, and possibly taking a good look at your health overall.
What about in physiotherapy, from that perspective, myths and misconceptions?
I think most people seem to often think that there's going to be no cure, well, we know there is no cure, but that's an inevitable process that's going to lead to joint replacement at the end of the day. And we know that's not the case. In fact, probably only about a third of people will show progression over time.
Michael, what do your patients
I think patients, they place too much emphasis on the Xray findings and that they've been led to believe that there's a tight link between Xray's findings and pain and disability. And while there's a loose correlation, it's only a loose one, and I think we need to be aware of that.
You'll see somebody with a terrible joint who's not got much pain at all.
That's exactly right.
Versus, yeah. So do you find people get scared easily?
They certainly can, yeah, and we want to avoid that.
And you talk a lot about the language that the GP might use, or even your non-verbal language, which might make things worse.
That's right, because we're dealing with a condition that's called degenerative, and people think that that's irreversible, and as Jeff said, that you can do something about it. So we don't want to send the wrong messages about this is a downward spiral.
So you don't want to look at the X-ray and go, oh my God.
That's right, yes.
What about from the pharmacy point of view?
I guess as a pharmacist, Norman, as community pharmacy is probably one of the first points of contacts for consumers seeking advice about what works and what perhaps doesn't work in the management of their osteoarthritis. And I guess this evening we're going to talk about some of the pharmacological options and the level of evidence for some of the more traditional and complementary options, I guess, that consumers come in seeking.
Well, to have osteoarthritis is to be a consumer of glucosamine, is it not?
Possibly, and I'm sure we'll cover that a little bit later.
Is there a single Australian with osteoarthritis who's not on glucosamine?
Possibly not.
The krill stocks of the world are gradually being
depleted by going to people's joints. Yes. Is there any evidence at all, David, that glucosamine makes the slightest bit of difference?
There's probably conflicting evidence about whether glucosamine does have an effect in osteoarthritis. Certainly there are some studies which suggest that there is some marginal evidence. Whether that translates into clinical benefit is something else that perhaps needs to be debated.
And it's only glucosamine sulfate there's any evidence for?
That's correct. So there are two salts, Norman. There's the hydrochloride salt and the sulfate salt, and certainly the studies which demonstrate a positive result are those using the sulfate salt.
Yet, on your pharmacy shelves, no doubt, you've still got both.
There may be, but certainly the sulfate salt is available on the RPBS.
Well, I interviewed a rheumatologist, a researcher in the United States, who had some evidence that glucosamine increases the risk of type 2 diabetes. Is that just a one-off or what?
I guess those were related to high doses of glucosamine, and that can be an issue in patients who have poor glucose tolerance, I guess, and that's certainly something that just GPs and pharmacists just need to bear in mind, particularly patients who are using high doses of glucosamine in the management of the osteoarthritis.
Right. So gentle scepticism, but if you want to take it at reasonable doses, you're not going to do yourself much harm, Jeffrey?
I think that's correct. I think people go to drugs like glucosamine and chondroitin as the first place. They've got a problem, they want to do something themselves, and so this is the easiest place to go. Across the back fence, Mrs. Smith says, oh, I've been taking this stuff and it works, and that's often how it starts. And I think as health professionals what we need to do is probably gently unpack that for them, because they'll be on it when they arrive, and we then have this opportunity to say, well, do you really think it helps? And perhaps you could stop it and see if you get worse.
Do you often find as a rheumatologist you get referrals for people where it's misdiagnosed, where in one way or the other it's either underdiagnosed or overdiagnosed?
I think there are a few common mimics of osteoarthritis of the knee and the hip which we need to consider, and probably orthopaedic surgeons see more of this than rheumatologists, but
because they've chopped it out and they can have a look at it, is that right?
Correct, and they love this kind of stuff. And I think there's also that view that, oh, well, osteoarthritis, orthopaedic surgeon rather than osteoarthritis, let's do something more general.
So what's the most common confusion?
Well, there are a number of them, but I think probably the commonest thing is radiating pain from the back, so from the facet joints or disc or other structures, giving pain in the lateral thigh or in the groin.
So the X-ray might show a little bit of osteoarthritis and you think, well, that's what it is.
That's what it is, but in reality you then do something about it and in fact it's something else. The other thing is hip osteoarthritis being felt in the knee, so that they swear black and blue that the knee is the problem, and then when you examine them, because we always examine the joint above and below the affected joint.
Of course we do.
Because
of course we do. You do it all the time, Michael, don't you?
Of course.
And pharmacists do it. I can see them doing it.
Yes, somehow. Yeah. That you would discover that in fact you reproduce the pain by examining the hip above. So I think there are some things that you need to consider when somebody comes in with a single joint that's affected by a process that you think is osteoarthritis.
But given that we used to think that rheumatoid arthritis was a disease of younger people, but in fact it's a disease of older people, to what extent are the inflammatory arthropathies confused for osteo?
Look, I think they can be, but the nature of the history is key, because it'll be an onset that, so if we're thinking of an inflammatory arthritis, the onset will be probably over a shorter period of time. There may be greater swelling, so soft tissue swelling.
And more bilateral than
And it
osteo.
may be bilateral, and they may have other joints involved. And so I think there can be confusion in the beginning, but I think as time goes on it becomes clear.
And what do we know about the causes? Because it's not necessarily grinding your joints to dust by jogging every morning, I hope.
No, well, in fact, jogging might still be a good thing overall for the cartilage, but I think there are a variety of what we might call modifiable and non-modifiable risk factors for osteoarthritis. The non-modifiable things are as we grow older, and as far as I know, we can't modify ageing as yet.
Speak
We're
for
working on it.
yourself.
The telomere is sort of out there, but
Winding down.
Winding down. Gender, depending on the joint, again, that's not a modifiable thing to any great extent.
Why are women more prone to osteo than men?
Some of it may be genetically determined, and certainly we know for other forms of osteoarthritis, so Heberden's nodes in the fingers, that appears to be far more related to a female onset. In the knee, bilateral knee osteoarthritis is more common in women. That may be related to obesity, but it may also be related to a genetic thing as well.
And there's theories about venous congestion and things like that, Michael, isn't there?
Yes, this comes up with the people who advocate glucosamine, which is supposed to be good for venous congestion. And but you can develop microthrombi in the ends of bones, which increases the pressure within the veins and can that's how you can attribute the nighttime pain to osteoarthritis. Yeah.
So Rana, what does this guideline tell us that we didn't know already?
Probably not a lot more from other guidelines. What it does is it captures the more recent evidence, and I think gives us a clear picture of where we've got a lot of research and where we don't have much research, and also gives us an idea of where the general consistency is around different treatment interventions. But essentially what the guideline does tell us is that there are a range of non-pharmacological and pharmacological options available for people with OA of the hip or knee, and that we should be using non-pharmacological strategies prior to pharmacological strategies, and ultimately a combination of the two.
Because I remember also covering this, the Tasmanian research, which really has contradicted the notion that you give up walking and running or what have you when you've got osteoarthritis, because in fact the people who keep on doing it seem to do better.
That's right. In fact, it should be the opposite. People should be exercising. Exercise is one of the cornerstones of non-pharmacological treatment for OA, and there are a lot of benefits to be gained from exercising.
And to what extent are the risk factors shared with other conditions? And maybe just, that it could be a vascular problem or just other problems that increase aging, like smoking, diet. Is there any relationship there at all?
Probably the biggest relationship is obesity. It's probably one of the biggest problems now. The increasing prevalence of obesity placing an enormous load through particularly the weight-bearing joints of the lower limb, and that's what's causing it's one of the greatest risk factors. And in fact, people who are overweight or obese are 2.5 times more likely to have OA of their lower limb joints than someone who's of normal weight.
And when they lose weight, have there been intervention studies looking at the effect on osteoarthritis?
Yep, there are. There's some good studies to show that losing weight is beneficial, and I think the data shows that weight loss of about 5% is what's needed to get some sort of significant benefits in terms of pain reduction and improve physical function.
And David, you must see it in your customers and clients that the impact on their lives must be enormous.
Absolutely. I think most of the people who are regulars in community pharmacy, I guess, are elderly, where mobility is an issue. They do rely on being able to get out to do their daily activities, and certainly limitation of function through osteoarthritis or the pain and the mobility that comes with it certainly does affect their ability to carry out their daily activities.
To what extent, Jeff, are we talking here about a clinical diagnosis as opposed to firing off an X-ray or even an MRI scan?
Well, I think
which will no doubt please Mr. Rudd immensely.
I think we could make enormous savings in the musculoskeletal area just by banning a few key investigations, high cost, high volume things like CT scans, MRIs and so on. There is no doubt that in musculoskeletal disease per se, the most important thing is a good history and a good examination, thinking about the functional problems that the patient has brought with them, and then the strategic use of investigations. And that may well involve an X-ray to confirm the diagnosis, but it may not mean much past that. It may mean no blood tests. The blood tests are not necessarily helpful in osteoarthritis. So it's a matter of good history, good examination, a good thoughtful bit of diagnostic reasoning, and you're probably 90% there. What
do we know about the people, and we all know people who've needed hip replacements in their 50s, early in life. What's going on with them? Do we know?
Yes, we don't know everything, but we certainly know that with hips in particular, prior trauma, so trauma probably prior to 30 years of age, so football and sporting related trauma may well be a feature of this. There may well be genetic elements to this as well, particularly acetabular dysplasia, so rather than having a nice firm cup for the hip to sit in, it's shallower. And this seems to increase the risk of degenerative arthritis later. So there are a number of factors. I don't know whether we can explain all of them, but if it's unilateral, you'd think of trauma. If it's bilateral, you'd think of dysplasia.
So some paediatrician might have missed a subluxable hip.
Oh, that test, Ortolani's test, I've almost forgotten about that.
Yeah. Let's take a look at our first case study, who's Ruby, a 71-year-old woman. Her husband's still alive. She's got 2 adult children, as you would expect to have their own children have babies. Anyway, she presents to your surgery, Michael, with symptoms of pain and stiffness in the right knee. Made worse when she's active, and she gets a bit of aching at night, Michael. She describes similar but milder symptoms in the left knee, and she's finding it to do the housework, and she's not getting out quite as much as she used to. She still smokes, has a couple of drinks a week, and yep, she's been to David's pharmacy and she's got her glucosamine. Well, in fact, she gets it from the supermarket. Sometimes it's a bit cheaper. So what do you reckon on Ruby, Michael? What are you going to do for her?
With the management of Ruby?
Yeah,
well,
or the diagnosis, indeed.
Well, yes, we need to make sure that she has actually got...
glucosamine overdose, nothing else to do with it. You know.
She has actually got osteoarthritis at the moment, and based on that story, she probably does. But once we've sorted that through...
well, not so quickly, Dr. Yelland. Just sorted this through. You're going to make a clinical diagnosis, or are you going to keep your radiological colleagues in the manner to which they have become accustomed?
Right, okay. Well, I think there is some role for initial investigations, and partly to exclude things, really, rather than to make an active diagnosis of osteoarthritis. So, occasionally you're going to miss the odd tumour, but hopefully if you'll pick that up by taking a better history than that's been provided here. For example, has she had cancer in the past? Has she losing weight? Those sort of things, red flag questions.
She'd love to lose weight, but she hasn't been losing weight. Okay. And you succumb, Dr. Yelland, and you do an X-ray, and here's what you find. Let's have a look.
Okay, so...
And you're in a country town, no radiologist, you're reporting your own X-rays. Thanks very much.
Okay, so, well, she's got markedly reduced joint space in the medial compartment of the knee, and there's some osteophytes there, and she's got sclerosis of the joint surfaces there, and on the lateral side's not so affected. So the findings are consistent with moderately severe osteoarthritis of the knee.
Any advantage, Rana, to weight-bearing X-rays as opposed to having them done lying down? Much better to go with a weight-bearing X-ray. Lying down, you can be a little bit deceived. The joint space may not appear as narrowed as it really is in a weight-bearing position, so you get a much more truer representation with a weight-bearing film. Right, and most tables can cope with that, the weight-bearing? The other thing that's quite beneficial with the weight-bearing film too is it can help give you an idea of the static alignment of the knee, and alignment of the knee will also indicate load. So a knee that's got more alignment is going in, perhaps say a varus direction, will be placing more load over the medial compartment and might be a little bit more risk of undergoing progression at a faster rate, so that you wouldn't get that information from a lying down X-ray. And of course, Jeff, if you were to be tempted to do other investigations on this woman, you might get the shock of your life, because according to a recent paper in the New England Journal of Medicine, a large number of these people will have meaningless tears of their menisci. That's right. And I think there are real problems with that, because we're starting off with the notion that we've probably made a diagnosis, we've got an X-ray there we're comfortable with, we've got a clinical scenario. The MRI then just adds uncertainty. It actually doesn't add anything to. So you then see things that might be surgically remediable. So you then move to the next step. Well, is there any evidence that... And then you really screw up her knee. Well, that's right. Well, does arthroscopy of an osteoarthritic knee... Well, that's going to be Michael's first thing, isn't it? You're going to refer her off for an arthroscopy and a lavage, aren't you? No way. So this is a place where... So just in case you think that, you're not sure about this, there is zero evidence for arthroscopy and lavage from 2 randomised controlled trials, despite the fact that no doubt an orthopaedic surgeon near you is actually still doing them. Absolutely right, and the problem is that the impact of studies now separated over about 5 or 6 years. The most recent is the Canadian study. Behaviour in those jurisdictions, Canada and the US and in Australia, unfortunately, is not odd. We're doing about as many arthroscopes in 50-year-old and 60-year-old women and men as we were doing 10 years ago, and I think that is concerning. David, apart from, this lady, Ruby, will have been to you before she comes to her GP, because she's been buying stuff over the counter to help her out. What do the statistics tell us about what people are using before they see their GP, what they're getting from the pharmacy and what they should be getting from pharmacists? I haven't looked at the most recent statistics on over-the-counter medication usage, but certainly simple analgesics and most of the medications we're going to discuss this evening are available over-the-counter, so things like paracetamol, anti-inflammatory drugs, the glucosamine, which we mentioned a little bit earlier. Most of these things are available either in pharmacies or supermarkets, so most of the patients, before they actually come to us or even to their GP,
would have at least tried something prior to seeking advice from a primary healthcare provider, I guess.
Well, I was going to do it later, but let's do it now with the medications. There have been randomised trials which suggest very little difference between paracetamol and non-steroidal anti-inflammatory drugs. What is the step up, if any, when you move to a non-steroidal in what's largely a non-inflammatory condition?
I guess for regular paracetamol is the standard or first-line management. Anti-inflammatory drugs may be helpful, and there may be some studies which suggest that there may be additional benefit from adding in a non-steroidal anti-inflammatory
Adding
agent.
in rather than replacing?
That's correct. And using the paracetamol as an anti-inflammatory sparing agent, I guess, and minimising their use. And if you are going to use an anti-inflammatory agent, then certainly using something that's shorter acting.
Such as?
Such as ibuprofen or diclofenac would be suitable alternatives for anti-inflammatory agents. Obviously, you need to bear in mind that they do have side effects, and some of those...
And just remind us the contraindications to non-steroidals.
Some of the contraindications and relative contraindications to anti-inflammatory drugs include things like a history of peptic ulceration, for example. Patients with hypertension and heart failure require monitoring and follow-up to ensure that their conditions are not exacerbated by the addition of anti-inflammatory agents. Patients with renal impairment are at risk of acute renal impairment from the addition of anti-inflammatory agents, particularly if they're also on ACE inhibitors or diuretic therapy.
What do you do for the patient who really shouldn't be given a non-steroidal? Panadol's not doing enough. Where to go next?
I think patients who are in that situation should probably already be managed by their GP, if not a rheumatologist, and certainly if they're being managed under a multidisciplinary team and undergoing the non-pharmacological options, and they've maximised their therapy. And I think the next step up for patients is opioid therapy is an option, but the side effects from the use of opioids, I think, far outweighs the benefits that you get from them. So there is a place for opioid therapy, particularly in patients with moderate to severe osteoarthritis and severe hard-to-control pain, or if they're awaiting surgery, I guess, for hip or knee replacement, but certainly for short-term use. But these patients who are affected by their mobility or osteoarthritis are also at increased risk of falls. So those are things that need to be considered in those patients.
Now, this is a program about the non-pharmacological treatment, which is really, the guideline suggests that's what you start with, and you have to move on from there. So just bear that in mind. We'll double back to the non-pharmacological treatment in a moment. I've fallen into the usual trap, but we'll come back to that.
PBS script book.
That's right, on the side. Goodbye. And here's your script. Michael, to what extent do you have to do other assessments on someone like Ruby in terms of fall risk, nutritional assessment, that sort of thing, before you move on with her?
Well, these are all essential for the non-pharmacological management of osteoarthritis. As you say, assessing fall risk because of the terrible consequences of falls, particularly in the elderly. The big issue of weight loss and assessing their ability to, or motivation to lose weight, and is another big thing. So assessing their degree of weight.
Yeah, and Ruby's not that fat. She smokes, and she's probably a bit thin. But yeah, does stopping smoking make any difference to osteo?
It affects just about everything else, but I don't believe it makes there's a lot of evidence for stopping smoking makes a difference to arthritis.
With medical students, the thing you ask them is what are the things that smoking doesn't make worse, because it's a shorter list.
That's right.
And I think osteoarthritis is one of those. Parkinson's disease and Crohn's disease, ulcerative colitis. So there's a very small number of things. And for totally different reasons, of course, you would be talking about cessation, but not because you would reasonably think it would make the pain better.
Might make the exercise a little bit easier. So let's go through what the non-pharmacological interventions are that are proven in osteoarthritis of the knee.
Exercise is one of them, and there's a range of exercise: land-based exercise, water-based exercise.
So let's just start there for a moment. People say that, actually, just one question I want to ask while we're on medications. I once saw a paper which suggested that non-steroidals make osteoarthritis worse.
There was a trial done in the late 1980s, early 1990s that showed that indomethacin made hip osteoarthritis progress faster. The concern was, did we make the pain less and so they did more and it progressed, or whether there was a direct effect, and there was some evidence. For the routinely used non-steroidals now, there's no evidence of progression.
Sorry to interrupt you, Rana. So, isn't gravity-based exercise better for you than swimming?
There's no evidence to suggest that one form of exercise is better than another. We've basically got two classes of exercise, if you like. You've got your aerobic type exercise, things such as walking, cycling, swimming, or you've got resistance training, so strengthening your muscle groups. And both of those classes of exercise will impart benefits in terms of
So
pain.
you want to build up your quads?
Yep. Quads is a key muscle in the lower limb, particularly because it's such a key muscle with most functional activities, and it's a major contributor to disability in arthritis and pain as well. So quadriceps is a key muscle. Also the hip muscles as well, obviously with hip arthritis, but even benefits for people with knee OA if they undergo hip strengthening training as well.
So the patient says, look, well, what do I do, to strengthen it? Mm-hmm. Do I have to go to the gym and go to one of those machines? What are the tips for exercises to strengthen your quads?
Look, I think the key thing, there's a number of ways it can be done simply in the home. You can use gravity and you can use body weight to strengthen muscles. You can use low-key types of equipment in the home, such as cuff weights or resistance bands, such as TheraBand, or you can go to something a bit more high-tech, such as the gym, and use equipment and be supervised.
So this is as simple as sitting in a chair and straightening your leg against resistance.
Yep, exactly. So you can put a weight around the ankle, you can use body weight where you're doing step-ups or hopping seated chair rises in and out of the chair. And in a way, they're perhaps some of the most important exercises, particularly if the patient's having difficulty with those functional tasks and it's not just pain.
So you're getting better at the activities of daily living.
Exactly. So not only are you getting the pain benefit, but you're getting improvements in function.
And what about stairs? Are stair exercises good?
Yeah, they're great. They're really demanding exercise for the muscles of the lower limb, and a really good way of strengthening the lower limb.
And what about reps and how often you should do it? What are those recommendations?
If you're trying to get a change in muscle strength, you're generally looking at about 6 to 8 weeks of participating in exercise before you'll see a true strength gain, and usually looking at probably 3 to 4 times a week. The more people exercise, the better the benefit is going to be. But the key there is maximising adherence. If you prescribe an exercise program to a patient and say, I want you to do these 10 exercises 6 days a week, probably the patient might do it for a week if you're lucky, and then their compliance is really going to drop off. So it's really finding the balance of giving the patient a regime that's going to give them a benefit, but also not be too much of a burden and cause them to stop exercising, in which case any benefits that they've gained will soon be lost.
Lots of questions coming in. One for you, Rana, which is from Meredith Bell in the Tamworth Pharmacy in New South Wales. Are there any other exercises you can suggest for a 130 kilogram male who was 140 kilograms? What was he? I don't remember him from Biggest Loser, but as he was. Besides walking, resistance bands and weights, lymphedema restricts his use of the hydrotherapy pool. Challenge.
That is a challenging case. As I said, you've basically got your two classes of exercise. So amongst your aerobic options for exercise, you want to choose something that's low impact to minimise the load on the joint. So of your low impact aerobic options, swimming's obviously out. You've already put walking down there as an option. Probably the only other one to consider would perhaps be stationary cycling, or cycling would be a good option. Then amongst the resistance training, you're really talking about strengthening muscle groups, and the idea there is to pick your key muscles that are weak, or the key muscles that are limiting particular functional activities. Typically, as I said before, we're going to be focusing on the quadriceps, the hamstrings, and probably also the hip abductors and extensors. You have got options there with cuff weights and TheraBand as is in the question, but perhaps if they're not viable options, what would need to be considered is changing body positions, so perhaps using gravity as an option, or body weight. So as I said, using some more functional tasks that are going to have the added advantage of improving function as well.
And what colour band do you start off with?
You start off with the easiest, or I would typically start with a graded exercise program and assess how the patient's going. And with coloured bands, generally it goes in terms of the colour. So the lighter colours are the lighter resistance, which is typically yellow, working up to...
So you don't start as a black belt?
Yeah, you wouldn't go for the black band to start with.
And just a question here, just from Chevron Island, John West, who asks about the frequency of exercise. Just wanted to pin you down on strengthening exercises and exercises and the number of reps, because I'm told that when you're doing strengthening, if you were doing it with supervision, they would find out what your maximum is and then come down 25%. And then do that, which is harder when you're doing it with just steps and things like that.
That's right.
But then there's things like 13 reps, 5 times, twice a day or something. What's the story here?
Look, what I would probably go for when someone's starting an initial program from a weakened level, you'd probably be looking at sort of an intensive sort of program for maybe over 8 to 12 weeks, and that's what most of the research studies have done. And you'd probably be looking at exercising maybe 4 to 5 days a week, once a day for strengthening. Maybe looking,
how many reps of each exercise?
Maybe looking at 2 to 3 sets of 10 to 15 reps.
Right.
Now that's a really rough rule of thumb, and it really shouldn't be something that's just applied out. In order to be effective, you really need to supervise the patient the first time with their dosage and with the repetitions and see that it's challenging enough, because that might not be challenging enough depending on the exercise. It's not going to be beneficial if either the exercises are pitched at too low a level or they're too challenging and you flare the patient up. Question from Marissa Pilla in North Queensland. We haven't heard from Marissa for a few weeks, so welcome back to the programme, Marissa. Just pinning you down on what are the trials and the Cochrane reviews saying about glucosamine?
They're really showing that it has, if anything, a very small effect, but most likely has no effect.
And another question is the extent of the differential between paracetamol and non-steroidals, and whether or not, in fact, you should be giving regular doses rather than PRN?
For paracetamol or?
Well, either or.
Either or. I think there is an advantage of non-steroidal anti-inflammatories over paracetamol, whether added or compared. The issue is the risk-benefit, and so you would always try patients on paracetamol, escalate the dose to the full 4 grams, and then if that was insufficient, you would then decide, depending on what their risk profile is, to possibly go to a non-steroidal anti-inflammatory. And it may be that you then, this is where the importance of talking to the patient and determining what the problem is. You may use a short-acting non-steroidal, less risk, because what they really want to do is to go for a walk or play their golf game or do whatever, and they don't need it the rest of the time. They can use paracetamol. So there's a variety, I think it's matching with it. But there is no doubt the non-steroidal works better, but the risks are higher.
Rana, a question here, again from Queensland, which is asking, is there a website you can go to which, for country doctors, where you don't necessarily have allied health, to actually explain how hydrotherapy should be done, so that a place you can go to find that out? To find out your practice nurse might want to teach people how to do it. Look, you're keeping this as arcane information just for physiotherapists.
Look, it's really something that is, you've got not just...
I feel like YouTube coming on.
There's no one spot. I mean, you've got there are a number of health professionals that can advise on exercise.
But is it just walking in the pool? I mean, against resistance, is that enough to get you the quads benefits?
It can be. There's some good research that shows, not so much walking in the pool, but there's some good research showing that land-based walking programs give good beneficial effects, and they can be, of up to moderate size, of a similar effect size of what we're talking about with paracetamol and NSAIDs.
Chris Barnett, a physiotherapist, New South Wales, just wanting a little bit more elucidation about our toing and froing on the randomised controlled trials on arthroscopy, debridement and lavage. Right. The extent of the placebo response, it was quite considerable, wasn't it?
Oh, it's enormous. There is no question that taking someone to theatre, anaesthetising them, putting 3 holes in their knee, and then telling them that they'll be better by an authoritative, generally male orthopaedic surgeon has a huge effect. And
Chris makes the comment that he has a preference for paracetamol because he believes that non-steroidals cause degeneration of the cartilage. But I mean, there is some evidence with ligamentous damage that they're not that great, isn't
there is, of re-injury and so on, yes.
So that's Ruby. Any evidence, Michael, that early detection of osteoarthritis makes any difference? In terms of interrupting the course?
Yes. I'm not sure if there's any clear evidence about that. maybe
There's
Jeff could.
been no trial. It's a very interesting thought, though. I think the NH and MRC would be interested.
And David, before we go on to our second case study, Ruby fancies taking a bit of fish oil. She's heard about you in South Australia, that's all you consume in Adelaide is fish oil. Is there any evidence for osteoarthritis? There's a bit of evidence for rheumatoid, but as we discovered in our last programme in the series, but what about osteoarthritis?
Thanks, Norman. We put fish
You're
oil
welcome.
in our water in Adelaide, actually.
Yeah.
It's good for everything. But
Well, you need it in your water.
as far as I'm aware, there's no current evidence that fish oil is beneficial in osteoarthritis, or at least there's no studies that have been done to demonstrate that, that I'm aware of.
Jeff?
Look, I think there probably is some small studies that it's a
Certainly it
hazard.
stops you having sudden death on your
Correct.
prevents you on your
it
exercise.
helps all kinds of other things. And the ones I can bring to memory immediately is combination with non-steroidal anti-inflammatories and an additional benefit. But there is so many other health benefits to fish oils, if appropriately provided, and it's the right kind of fish oil, that the risk benefit looks better for that than it does for what we were talking about before.
But David, it's a lot more than just a couple of capsules a day. This is really talking about 15 mils of the actual oil.
That's correct. So you need to buy the concentrated oil and take a fair amount. It's about 20 mils of the proprietary product, but certainly
swallowed down with South Australian water.
with South Australian riverland oranges.
Yes, that's right.
But certainly the capsules that you get is certainly not enough. You'll need about 10 capsules from the
So
usual
it's cheaper
fish oil
with the
capsules.
oil.
That's
You're
correct.
happy to take it. So let's go to our second case study. This is Harry, who's in his late 50s. He's got two sons. They're twin sons aged 10. That means he's under pressure, second time around, two families to look after. He comes to you with right-sided groin and lateral thigh pain, radiating to his anterior thigh Michael. And when you examine him, he's got tenderness over the greater trochanter, the right hip, and reduced hip movement, and a bit tender when you try to abduct, internally rotate or extend his hip. He thinks he might have a hernia. He's a builder, and he's a bit worried about what you might tell him is going on. You're a patient.
Right. Yes. Okay. Well, I think we need to clarify the diagnosis here. Just because he's got anterior groin pain doesn't mean he's got osteoarthritis.
He could have a hernia.
He could have a hernia. Of course, you can check him out for that. And he's also got lateral. He's got lateral tenderness. He's got greater trochanter tenderness, which always makes me think about back problems. And so I'd certainly be examining his back, and if I'd satisfied myself that wasn't the cause, then perhaps he does have osteoarthritis. We'd need to deal with that question about X-raying him at that stage too, and
He doesn't believe you, so you send him off for an X-ray of his hip, and here's what you find.
Okay, so in this X-ray we see degenerative changes in both hips, and more so on the right with erosion of the cartilage there. The joint space is very narrowed, and there's sclerosis above the head of the femur, and some lateral osteophytes as well. So he's got osteoarthritic changes bilaterally, worse on the right.
What are you going to do for him?
First of all, if we're going to talk about the condition itself and do some education about it, and
Yeah, which is something we didn't talk about with Ruby's case. There is evidence that knowledge reduces pain.
So that's right. So explain the pain process to him, and that this doesn't mean that he has to stop being active. In fact, we'd encourage him to stay as active as possible, and reassure him that quite a lot can be done for this condition, and so take a positive approach. We certainly should avoid firecracker words like degeneration and your hips are crumbling and so on, and start talking about
Firecracker words.
That's
a great term.
Yes, the need for surgery in the very near future and so on. I think we don't wish to alarm him. We wish to empower him to get involved in this management and to do as much as he can to get better.
But what do we know about what you can do non-pharmacologically for osteoarthritis of the hip? I thought it was questionable whether exercise makes any difference to the progress here.
The reality is, with regards to the hip, we've got very far fewer research studies than we've got at the knee. So one of the limitations of the current guideline is that most of the vast majority of the evidence contained within the guideline has come from studies of patients with knee OA, and we're assuming that it will apply equally and similarly to patients with the hip.
Wasn't there a study of hydrotherapy which showed minimal effect?
Yeah, there is one or two studies that show minimal or no effect. However, there's been a couple of clinical trials that have shown small effects of other forms of exercise around the hip.
Such as?
For strengthening, so a muscle strengthening program.
So give me an idea of what are the sort of pelvic girdle, thigh type
What types
exercises?
of exercise?
Yes.
So for sort of simple sort of home exercises for hip osteoarthritis, you can again in side lying or prone or supine positions strengthen all of the muscles around the hip. Either depending on how weak the patient is, you may not, just the weight of the limb against gravity may be enough initially, but then you can.
So lying on your side and raising the leg.
Will strengthen the hip abductors. You can do some bridging type exercises to strengthen the extensors. Now that would be for someone, you'd have to
So when you say bridging?
Bridging, that's in supine, so you'd have sort of in a crook lie position with your knees bent up, and then you lift your backside up in the air, so you're actually extending off the bed.
Oh, I see. Okay, right.
So that would be a sort of a starting
Arching up
point.
as if somebody's sticking a pin in your bum.
Exactly that.
Right.
Then you can progress into standing positions where you're probably using TheraBand or the resistance band is the best way to go, and you need to have some household furniture that's positioned in an appropriate way, but tying the resistance band around the leg of a table that's quite sturdy, and then you can exercise
yes, you just
the
imagine dragging the table around.
Yeah,
the
that's
house
right. If it's not heavy enough, so you can exercise the hip in pretty much most planes.
So, is there an equivalent muscle group to the quads in the hip that are critical to the hip?
It's a good question. The answer is we don't know at the moment, and the problem is there's just been a real lack of research into. Particularly into understanding the sort of biomechanical impairments that exist with hip OA. We know a lot about knee OA, that quadriceps weakness plays a really key role. We can assume that around the hip that there's going to be similar muscle weakness, and probably the hip abductors and extensors are probably, theoretical rationale suggests they would be the most beneficial muscles to strengthen. They're quite key in stabilising the pelvis and in walking, but there's a real lack of research to help guide us with interventions.
And what about the core muscles, the psoas and so on, which, the plank type exercise, do they make any difference to the hip?
They will. They work. The further proximally you go up the chain, the more important the core is. And what you often see clinically is patients with hip OA often have a lot of spinal pain as well, and it often goes hand in hand, which can make it a little bit tricky to actually exercise these patients, because then you've got the fine balance of coming up with an exercise program that's beneficial for the hip, but that doesn't aggravate the lumbar spine, for example.
What are you going to do with Harry? I mean, you start having Michael has this conversation with Harry about exercise, and he stops him and he says, "Listen, I'm a builder. I'm up and down stairs all day, up and down ladders. I don't stop moving until I get home at night."
And look, I think that's a good point, because that's where education's the key. Patients will often think that, well, I'm physically active, that's exercise, and there's a difference between doing physical activity that's part of the day and to actually doing a specific exercise that's there to impart a key physiological response.
But the other thing he's going to tell you is, I've got to be on the site at 7 in the morning. When do I do my exercise?
And that's why it's really important to work with the patient, engage with an appropriately trained health professional to actually work out what's going to fit his lifestyle, because if he doesn't do it, he's not going to get any benefits from it.
And to what extent is a buddy important? In other words, having somebody there to help you through rather than doing it by yourself?
Research shows that having motivation, that's probably one of the reasons why group exercise is quite effective, particularly at the outset when starting an exercise program, because it gives you not only is it motivating and you have the social interaction, but it often gives you another reason to go and attend. You know, just when you might be thinking, oh, I've had a tough day, if someone else is going along, it can drag you out.
More and more country towns have walking groups, but this is more than just a walking group, isn't it, Jeff? I mean, this has got to be systematic.
Well, there are various approaches, but you certainly need, and ideally the buddy is even trained and empowered to sort of be involved. But certainly we're social beings, and making things social activities it's all about adherence. It's about getting through to that sort of 3 or 4 month mark where it becomes a routine in your life. And if you can get there, often the sustaining factors are better.
It's a behaviour change, and that takes a while to do.
Michael?
Yeah, could I just add in that there was a recent meta-analysis of exercise for HIPPO-A studies, which had about 9 studies in it, and 8 out of 9 were positive, 1 was negative, the biggest one. But in that study, they just did home exercises, as opposed to the other 8 where they actually had supervised exercises. So it's a bit of a plug for the physios, and I know it's difficult in remote areas to get access to that, but where you can, get that health professional to instruct people and to motivate people, I think you'll do a lot better. Yeah. And they're about as effective overall as paracetamol. You know, they did have an effect size in these studies about as effective as paracetamol as a pain reliever. Yeah.
Sorry, I was going to say the other option for remote areas to also help improve adherence with exercise is to provide the patients with either a detailed instruction booklet or even an audio or video material as well. That can help improve adherence with exercise.
But all I was going to say is we've all met Harry. Hundreds of Harrys are out there in rural, remote, metro, and they're tricky because they don't come back. You know, he'll get the diagnosis and he'll disappear. So those early discussions are very important to kind of get him thinking about what this means for him, because it's going to have a huge impact on him whether or not he goes to a hip replacement or not. This is something where he needs to be engaged in his own health, and it might be the first time he's ever thought about his health.
Yeah. To what extent does this delay or avoid the need for hip arthroplasty? Because he's going down that road, he really is, isn't he?
He is, and I don't think we really know whether interventions that we're talking about would do more than just delay it, but they're in hip. In knee, it may well be that you'll remove some from the waiting list forever, but with hip, I think there's less evidence that you may just alter the natural history and deliver someone to the surgeon in a much better position.
So he says, Doc, I haven't got time for all this. Give me one of those injections into the hip that everybody seems to swear blind by.
So the cortisone?
Yeah, well, yes. I assume that's what Harry's talking about, yeah.
Okay. Yes.
Mix in a local anaesthetic if you want, that would be better.
Of course, yeah. These do have some role in patients who are, in a pretty bad way and having an acute flare. And so I think there is a role, but there's a limit to them as well, and generally 3 per year. And the other problem with these is if they are heading for an operation, that injections within 3 months of surgery may carry an increased risk of infection with the surgery. And that's extrapolating from shoulder studies, I must admit. But, an infection in a hip replacement is a disaster for the patient and for the surgeon.
Any risk in injecting the hip that you prang the artery to the head of the femur?
Generally, we would ask the radiologist to perform an injection into the hip because it's a long way down.
Right. So it's not for the faint-hearted.
No.
Or for the amateur. Let's go to our third case study, which is actually a film, which follows the story of Alex, who's been referred by his general practitioner to the Bendigo Osteoarthritis Hip and Knee Service. These are really interesting services and they're spreading around the country. Let's have a look at the Bendigo experience.
To have osteoarthritis, I can tell you, is very, very painful. It is not only during the day when you're trying to walk around and be mobile, even at night time when I try to sleep. The pain is constant. I'm here to see Theo. He's going to have a look at my knees.
Mr. Pinkster?
Miss Pinkster, yeah.
The osteoarthritis hip and knee service is
designed to optimise the management of patients referred for hip and knee osteoarthritis by their GPs.
We were aware of the increased waiting list in this category of patient, and following the trial of a project in metropolitan hospitals in Melbourne, we were very keen to be the first regional hospital to provide this service.
The initial evaluation is a comprehensive assessment as well as filling in of a standardised questionnaire that was purposely developed for the osteoarthritis hip knee service. The questionnaire is resent at regular intervals, and any change, whether it be positive or negative, is noted and acted upon.
When I do the gardening, I find that I have difficulty when I'm whippersnipping.
I want to collect, I guess, as much information as I can so that I can understand the burden of arthritis on Alex as an individual.
So after 2 hours or so, I'm in real pain.
Can you tell me what medication you take for your pain?
I take Valium.
There's a lot of education about the correct use of medications. And if in fact we assess that pain is severe and significant, we can let the GPs know that they can potentially give them more stronger pain relief. So there's a lot of communication with GPs about that aspect of it. You can see on the inside of both the left and the right knee, the space between the two bones is a lot narrower.
Right.
And that usually indicates that your cartilage has become thin and your cushioning between the joints has narrowed, so you're getting more pressure on your bones.
Okay.
It's a typical feature of osteoarthritis. You also have... He is not keen or actually ready to proceed to knee replacement because he's still functioning quite well and his symptoms are relatively mild. Plus he has a lot of other contributing factors that haven't been addressed fully, so there is scope for a variety of non-operative measures that may be able to improve his symptoms and keep his function adequate and pain under control and potentially not need to have his knees replaced for quite a long time. The osteoarthritis hip and knee service is a multidisciplinary service. We understand that appropriate management of osteoarthritis requires lots of professionals and expertise. I'd like to refer you to the physiotherapist and exercise therapist at our rehabilitation campus for more strengthening and improving in your general fitness and function.
Okay.
I'd like to have opinions of several professionals to try and optimise every aspect of your care.
So he put me in contact with James, who is also a physiotherapist.
So what I'll do is just do some little movements on the kneecap.
Who also assessed me and tried various exercises and manipulations of the knees.
Just when you were pushing underneath.
Like that?
I was also put in contact with a dietitian to lose some weight because that has an impact on my condition.
One of the things is about your alcohol intake, because alcohol has lots of calories and you're drinking about 3 to 4 glasses per day.
That's correct.
Yeah.
Being overweight significantly increased pain and disability with arthritis and also potentially progress the condition. And in Alex's case, his body mass index was 37, which puts him well and truly into the obesity range. So it's an important aspect for his particular care.
Just halfway, not too deep.
Okay. He also then put me in contact with Matt, and he supervises my gym work specifically for the knees to try and strengthen them or ease some of the tendons that the pain will be less.
So there was no swelling, increase in swelling?
It is a program that is under supervision in the gym work, in the hydrotherapy, and there is someone who says the progress is fine or no, we need to change tack and try something different.
We have noted from our review process that probably 2/3, 3/4 of our patients that were deferred from surgery improved the health status with the conservative measures that were instituted. The group that needed surgery, many of those patients have improved their hip and knee questionnaire scores as well. It essentially means that when they turn up for their surgery, they are fitter and more comfortable and have a better understanding of what is required to recover from their operation, and in fact are more likely to have a more rapid recovery.
The Oaks service alone has halved our orthopaedic waiting list for patients to come into outpatients, which is amazing in 18 months. It's actually taken out those patients that don't need to go to surgery yet, so that they're seen by the physio rather than the surgeon. It decreases then those patients that go take up surgeons' time. So the surgeons are now seeing more patients and they're seeing the patients that are likely to need surgery. When I sent out the patient satisfaction survey, they were just raving about how fantastic it was, how people spent time to listen to them, and how they were actually able to walk again and do things in the community. That's given them that ability to re-engage in life, because you get pain, you can become isolated. When you isolate them, it's a self-perpetuating problem. So to be able to give them options and give them things that they can do and ways to manage their pain gives them that benefit.
I feel it has made a difference. It has only been 3 months, but some of the pain is less, and I have certainly maintained some of the more of the mobility than I had in the past, and hopefully this will continue. And the idea is to hopefully avoid surgery, because I like to keep my own knees for as long as possible.
Alex and Bendigo, orthopaedic surgeons run a love for these clinics, don't they? Because essentially they're consultant-led, not consultant-led, but the consultant supervised with physiotherapist-led.
That's right. It really does take the load off the orthopaedic surgeon, and it ensures that the people who see the orthopaedic surgeon are the ones who really need to see.
So their hit rate for surgery goes up.
Yeah, that's right, at that time. And also, I think the other important thing is that people are getting to see physio in a more timely manner, rather than waiting 3, 4, 6 months down the track after the orthopaedic surgeon has seen them and able to refer. They're getting their physio and therefore starting on their exercise programs much earlier, which helps to limit some of that functional decline that can happen with progressive muscle wastage.
Michael, what are the specifics then, do you think, that are different from the city in terms of looking after people with osteoarthritis, the challenges and some of the solutions?
In rural areas?
In rural areas, yes.
In rural areas, well, partly access to assistance from allied health professionals is one thing, of course. Access to surgical facilities if they're needed for the more severe patients, and perhaps in the farming community and so on, I think they do actually have there's a lot more manual labour involved and so on, so they're more demanding. And this is another risk factor for osteoarthritis is sort of repetitive trauma and repetitive lifting and hard work and so on.
Jeff?
I've worked in a rural area for the last 15 years, and I would say that it's changed enormously. That I think 15 years ago you were really pushing it uphill to get services and to provide things, and I think we're now seeing services being provided. Allied health is more available than it used to be. The GPs are very empowered and engaged. They're part of the community. I mean, sometimes I wonder whether we need to emulate some of what we're seeing in our rural cities, in outer metro.
But what about Indigenous specific issues for Indigenous communities? Because, you know, in many ways they might get osteoarthritis earlier and worse than the white community.
I'm not sure there's evidence, but that is a reasonable thing to say, and the problems there would be the same as in thinking about Indigenous health, is where they are. So are they in a remote area where they probably won't have access to some of those things, and they'll be relying on sparser services? But equally in those metro-dwelling Indigenous populations, you know, accessing and remaining engaged in their own care is also very important.
What about rules of thumb for setting up one of these multidisciplinary teams?
I think the main thing is having a... You don't have to have, that's obviously quite an extensive service they've got there in Bendigo, but I think as long as you've got a physio, access to a consultant orthopaedic surgeon, and some facility for delivering you know, the non-pharmacological interventions. It doesn't have to be the fancy gym that we've just seen in Bendigo. Patients could still be seen by a physio, and even if there's not regular access, and set up with a really good home exercise program and other strategies that might entail self-management, that can still work.
Don't think we've got the answer to our poll question yet, but I'll ask you for your takeaway messages, then we'll come back to the answer to our last poll question about how access to orthopaedic surgeons. What's your takeaway message for those watching, David?
I guess my takeaway message really is that for osteoarthritis, there's really no cure or disease-modifying agents for the management of osteoarthritis, and the pharmacological options really need to supplement or complement the non-pharmacological options. And I guess community pharmacists are well placed to provide advice, and there's a good network of community pharmacies in rural and remote Australia, and they can certainly help reassure people like Harry and Ruby about the pharmacological options and their management of osteoarthritis.
Michael?
My key message about management, I think, would hark back to the diagnosis and reassuring your patient that things can be done. So be careful about those firecracker words about degeneration, things are falling apart, and you're heading for a hip replacement, etc. And focus more on the positives. Be careful with your X-rays and how you explain them to patients.
Rana?
My key message would be that exercise is pivotal for all patients, and there's a form of exercise there or a type of exercise that suits any patient, no matter how mild or severe, and that the key to long-term success is coming up with a strategy that maximises adherence.
Jeff?
And in addition to all the wonderful words we've heard, it's also that osteoarthritis as a symptomatic presentation can be the beginning of a wider health discussion with your patient and kind of lock them into some other discussions that are necessary.
Which shows that you enjoyed this program on the new guideline on non-surgical management of hip and knee osteoarthritis. If you're interested in obtaining more information about the issues raised in the program, there are, as always, a number of resources available on the Rural Health Education Foundation's website, rhef.com.au, including a link to this new guideline. Our thanks to the Department of Health and Ageing for making the program possible, but thanks to you for taking the time to attend and contribute. Now don't forget to complete and send in your evaluation forms and register for CE points. I'm Norman Swan. See you next time.